Question 1. Topic: Vestibular disorders. 50-year-old male presents with sudden onset of severe vertigo, nausea, and vomiting. He reports no hearing loss or tinnitus. The symptoms started suddenly and have persisted for several hours, worsening with head movements. Examination reveals horizontal nystagmus that is suppressed with visual fixation. The head impulse test is positive. Which of the following is the most likely diagnosis? A. Meniere's disease. B. Vestibular neuritis. C. Benign paroxysmal positional vertigo. D. Acoustic neuroma. Answer: B. Vestibular neuritis. Explanation: vestibular neuritis is a viral or post-viral inflammatory disorder affecting the vestibular nerve, leading to acute vertigo without hearing loss. Key diagnostic features include sudden onset of vertigo, nausea, and vomiting, persistence of symptoms for hours to days, no auditory symptoms, differentiating it from Meniere's disease. Horizontal nystagmus that is suppressed with visual fixation. Positive head impulse test indicating peripheral vestibular lesion. Incorrect answers: Meniere's disease. A. Presents with episodic vertigo, but it is typically accompanied by fluctuating sensorineural hearing loss, tinnitus, and ear fullness, which are absent in this KBP. C. Causes brief episodes of vertigo triggered by head movements lasting seconds to minutes. It is diagnosed with the Dix-Hallpert maneuver, not the head impulse test. Neuroma. D. Presents with progressive unilateral sensorineural hearing loss, an imbalance rather than acute vertigo. Relevant guidelines: the American Academy of Otolaryngology Head and Neck Surgery (RHNS) guidelines emphasize using the head impulse test to differentiate between central and peripheral causes of vertigo. The Barony Society recommends vestibular rehabilitation for recovery in vestibular neuritis. Question 2. Topic: Head and neck cancer. Which of the following patients has the highest risk of developing oropharyngeal squamous cell carcinoma, OPSC? A. 25-year-old male with history of recurrent streptococcal pharyngitis. B. 45-year-old male with chronic gastroesophageal reflux disease, GERD. C. 55-year-old male with 30-pack years smoking history and excessive alcohol consumption. D. 60-year-old female with Sjogren's syndrome. Answer: C. A 55-year-old male with a 30-pack year smoking history and excessive alcohol consumption. Explanation: oropharyngeal squamous cell carcinoma, OPSC, is strongly associated with tobacco and alcohol use as well as human papillomavirus (HPV) infection. The highest risk factors include long-term tobacco use, cigarettes, cigars, or smokeless tobacco, excessive alcohol consumption, which has a synergistic effect, smoking, HPV-16 infection, particularly in non-smokers. Incorrect answers: recurrent streptococcal pharyngitis. A. While chronic infections can cause inflammation, A. are not a major risk factor for OPSC. GERD. B. GERD is a risk factor for laryngeal and esophageal cancers, but not strongly linked to OPSC. Sjogren's syndrome. D. This autoimmune disorder affects salivary glands and increases the risk of lymphoma, but is not primary risk factor for OPSC. Relevant guidelines: the National Comprehensive Cancer Network (CN) guidelines stress the role of tobacco and alcohol cessation in reducing head and neck cancer risks. HPV-related OPSC is increasingly recognized, with HPV vaccination recommended for prevention. Question 3. Scenario-based. Pediatric otolaryngology. Emma, 3-year-old girl, is brought to the emergency department by her parents due to sudden onset of difficulty breathing, barking cough, and inspiratory stridor. Her symptoms worsened at night. On examination, she has mild fever, inspiratory stridor at rest, and harsh barking cough. Oxygen saturation is 96% on room air. Which of the following is the most appropriate initial management? A. Nebulized epinephrine and dexamethasone. B. Broad-spectrum antibiotics and romanoids. C. Immediate intubation in the operating room. D. Bronchoscopy to evaluate for foreign body. Answer A. Nebulized epinephrine and dexamethasone. Explanation: Emma's symptoms are highly suggestive of laryngotrachobronchitis, croup, which is caused by parainfluenza virus. The key clinical features include barking cough, inspiratory stridor worsening at night, fever, and respiratory distress management. Nebulized epinephrine reduces airway edema and improves symptoms. Dexamethasone oral or IM helps reduce inflammation and prevents airway obstruction. Incorrect answers: antibiotics and romanoids. B. Croup is viral, not bacterial, so antibiotics are not first line unless secondary bacterial infection, bacterial tracheitis, is suspected. Immediate intubation. C. Intubation is only needed in severe cases. with impending respiratory failure. Most cases respond to medical therapy. Bronchoscopy. D. Foreign body aspiration presents differently at sudden choking, asymmetrical breath sounds, no fever. A history of choking is often present. Relevant guidelines. The American Academy of Pediatrics recommends corticosteroids for all patients with croup and nebulized epinephrine for moderate to severe cases. The Wesley-Croup score is used to assess severity and guide treatment decisions. Question 4. Topic: Otology and Neurotology. Vestibular disorders. 56-year-old woman presents to your clinic with episodic vertigo that lasts for several hours at a time. She describes sensation of fullness in her right ear and has noticed fluctuating hearing loss over the past few months. Tinnitus is also present in the affected ear. On physical examination, no signs of infection or neurological deficits are noted. Audiometry confirms low-frequency sensorineural hearing loss in the right ear. Which of the following is the most likely diagnosis? A. Benign paroxysmal positional vertigo. B. Meniere's disease. C. Vestibular neuritis. D. Acoustic neuroma. Answer: B. Meniere's disease. Explanation: Meniere's disease is characterized by the classic triad of episodic vertigo, fluctuating sensorineural hearing loss, typically low frequency, and tinnitus, often accompanied by feeling of oral fullness. The exact cause is thought to be endolymphatic hydrops and a normal accumulation of fluid in the inner ear. APPV typically presents with short-lived vertigo triggered by head movement and is not associated with hearing loss. C. Vestibular neuritis causes sudden onset vertigo but does not cause fluctuating hearing loss or tinnitus. D. Acoustic neuroma, vestibular schwannoma, often leads to progressive, unilateral sensorineural hearing loss, an imbalance rather than episodic vertigo. Management includes dietary modifications, low diuretics, vestibular rehabilitation, and intratympanic steroid injections in severe cases. Question 5. Topic: Laryngology. Vocal cord disorders. 40-year-old professional singer presents with progressive hoarseness over the past 6 months. She denies smoking but reports frequent voice strain due to her occupation. Laryngoscopic examination reveals bilateral, small, symmetric lesions on the mid-portion of the true vocal cords. Which of the following is the most appropriate initial management? A. Voice therapy and vocal rest. B. Immediate microlaryngoscopic surgery. C. Proton pump inhibitors (PPI) for suspected laryngopharyngeal reflux. D. Antibiotic therapy for possible bacterial laryngitis. Answer: A. Voice therapy and vocal rest. Explanation: This patient likely has vocal cord nodules, which are benign, bilateral lesions caused by chronic voice misuse or overuse. Initial treatment involves voice therapy with a speech-language pathologist and strict vocal rest to reduce strain and allow healing. B. Surgery is reserved for persistent nodules that do not respond to conservative management. C. PPIs are useful. Laryngopharyngeal reflux (EPR), which can contribute to voice issues but are not first line in the absence of reflux symptoms. D. Antibiotics are unnecessary as bacterial laryngitis is rare and the chronic nature of the symptoms suggests a non-infectious etiology. Preventive strategies include hydration, avoiding vocal strain, and using proper vocal techniques to prevent recurrence. Question 6. Scenario-based question. Topic: Pediatric otolaryngology. Airway disorders. Dr. Reynolds, pediatric otolaryngologist, is consulted for 3-month-old infant with noisy breathing that worsens when crying or feeding but improves when the child is prone. The parents report that the baby has been making high-pitched, stridorous sounds since birth, which has gradually worsened. The infant is thriving and has no history of cyanosis or significant feeding difficulties. What is the most likely diagnosis and how? Dr. Reynolds proceed. A. Tracheomalacia. Perform rigid bronchoscopy immediately. B. Laryngomalacia. Reassurance and close follow-up. C. Subglottic stenosis. Schedule immediate airway dilation. D. Vocal cord paralysis. Obtain immediate imaging to assess for underlying CNS pathology. Answer: B. Laryngomalacia. Reassurance and close follow-up. Explanation: Laryngomalacia is the most common congenital cause of stridor in infants. It results from floppy supraglottic structures that collapse during inspiration. Key features include worsening stridor with activity, crying, feeding, and improvement when prone typically self-resolves by 1 to 1.8 months. A. Tracheomalacia involves the trachea and often presents with expiratory stridor, not inspiratory. C. Subglottic stenosis is more commonly associated with history of intubation and presence with biphasic stridor. D. Bilateral vocal cord paralysis is concerning but usually presents with respiratory distress at birth. Management is typically conservative unless there are signs of failure to thrive, severe airway obstruction, or apnea. In case supralarplasty may be indicated. Question 7. Topic: Head and neck surgery. Thyroid and parathyroid disorders. 52-year-old woman with history of osteoporosis and kidney stones, presents with fatigue, depression, and muscle weakness. Laboratory tests show elevated calcium, low phosphate, and increased parathyroid hormone pH levels. CertMedbry scan identifies hyperfunctioning parathyroid adenoma. What is the definitive treatment for this patient? A. Parathyroidectomy. B. Bisphosphonate therapy. C. Calcium and vitamin D supplementation. D. Observation and serial calcium monitoring. Answer: A. Parathyroidectomy. Explanation: this patient has primary hyperparathyroidism, commonly caused by a parathyroid adenoma. The best treatment is surgical removal of the affected gland. Parathyroidectomy, particularly in symptomatic patients. B. Bisphosphonates help manage osteoporosis but do not address the underlying parathyroid disorder. C. Calcium and vitamin D may be needed post-surgery if transient hypocalcemia occurs but are not the primary treatment. D. Observation is only considered for mild, asymptomatic cases in elderly patients. Surgical removal results in long-term cure with normalization of calcium metabolism. Question 8. Topic: Rhinology. Sinus surgery complications. Patient undergoes endoscopic sinus surgery for chronic rhinosinusitis with nasal polyps. During the procedure, the surgeon notes profuse clear fluid leakage from the ethmoid region. Which of the following is the most likely cause of this finding? A. Allergic reaction to surgical instruments. B. Cerebrospinal fluid (CSF) leak due to skull base injury. C. Active infection with Staphylococcus aureus. D. Nasal mucosal injury causing excessive serous drainage. Answer: B. Cerebrospinal fluid (CSF) leak due to skull base injury. Explanation: CSF leaks during sinus surgery occur due to unintentional skull base perforation, most commonly in the cribriform plate or ethmoid roof. This poses a risk for meningitis and requires immediate repair using grafts, fascia, synthetic materials, or mucosal flaps. A. Allergic reactions do not cause fluid leakage. C. Active infection may cause pus drainage, but clear fluid is suspicious for CSF. D. Mucosal injury does not cause continuous, clear fluid loss. Postoperatively, patients should avoid straining, nose blowing, and Valsalva maneuvers to prevent persistent leakage. Question 9. Topic: Otology and neurotology. Sudden sensorineural hearing loss. 47-year-old man presents with sudden onset hearing loss in his left ear that started 24 hours ago. He denies any recent infections, trauma, or opotoxic drug use. He reports mild tinnitus but no vertigo. An audiogram shows profound sensorineural hearing loss in the affected ear. Otoscopic examination is normal. What is the most appropriate next step in management? A. High-dose oral corticosteroids. B. Immediate MRI of the brain and internal auditory canals. C. Hyperbaric oxygen therapy. D. Intratympanic steroid injection only. Answer: A. High-dose oral corticosteroids. Explanation: idiopathic sudden sensorineural hearing loss (SR) is an otologic emergency characterized by sensorineural hearing loss of 30 dB in at least 3 contiguous frequencies within 72 hours. The first-line treatment is high-dose oral corticosteroids, prednisone IMEAG daily for 1014 days. BMRI is recommended if symptoms persist or retrocochlear pathology e.g. vestibular schwannoma is suspected. C. Hyperbaric oxygen therapy is considered an adjunct therapy in cases that do not respond to steroids. D. Intratympanic steroids can be used if oral steroids fail or are contraindicated, e.g. diabetes, immunosuppression. Prompt treatment improves recovery rates, but many patients experience residual hearing loss despite therapy. Question 10. Topic: Pediatric otolaryngology. Recurrent otitis media. 2-year-old boy presents with frequent ear infections, 6 episodes in the past year. His parents report delayed speech development and difficulty understanding commands. Tympanometry shows flat tympanogram bilaterally. An otoscopic examination reveals bilateral middle ear effusion. What is the most appropriate management strategy? A. Observation with serial audiograms. B. Tympanostomy tube placement. C. Long-term antibiotic prophylaxis. D. Adenoidectomy without tympanostomy tubes. Answer: B. Tympanostomy tube placement. Explanation: Recurrent acute otitis media, 3 episodes in 6 months or 4 in 12 months, and persistent otitis media with effusion causing hearing loss warrant tympanostomy tube placement. A. Observation is appropriate for children with asymptomatic OM, but this child has speech delay and hearing concerns. C. Long-term antibiotic prophylaxis is not recommended due to antibiotic resistance risks. D. Adenoidectomy alone is not indicated unless the child has adenoid hypertrophy causing nasal obstruction. Tympanostomy tubes help restore hearing, reduce infection risk, and support speech development. Question 11. Topic: Head and neck oncology. Thyroid cancer. 38-year-old woman undergoes total thyroidectomy for 2.5 centimeters papillary thyroid carcinoma. Postoperatively, she is found to have bilateral recurrent laryngeal nerve injury, resulting in complete vocal cord paralysis. What is the most immediate concern, and how should it be managed? A. Airway compromise. Perform tracheostomy. B. Voice loss. Consider medialization, laryngoplasty. C. Hypocalcemia. Initiate intravenous calcium. D. Hypothyroidism. Start levothyroxine therapy. Answer: A. Airway compromise. Perform tracheostomy. Explanation: bilateral recurrent laryngeal nerve (RRN) injury causes complete vocal cord paralysis in paramedian position, leading to severe airway obstruction and stridor. Immediate airway management is necessary, often requiring tracheostomy. B. Voice loss is secondary concern but can be addressed after airway stabilization. C. Hypocalcemia due to hypoparathyroidism. Common post-thyroidectomy but does not present as an acute airway emergency. D. Hypothyroidism is expected but managed in the long term. Patients with unilateral RRN injury may benefit from voice therapy or laryngeal framework surgery, but bilateral injury mandates airway intervention. Question 12. Topic: Rhinology. Epistaxis management in coagulopathy. 70-year-old man on warfarin therapy for atrial fibrillation presents with severe recurrent epistaxis. Examination reveals active posterior nasal bleeding. His inner is 3.8. What is the most appropriate next step in management? A. Anterior nasal packing. B. Cauterization with silver nitrate. C. Posterior nasal packing and reversal of anticoagulation. D. Observation and topical vasoconstrictors. Answer: C. Posterior nasal packing and reversal of anticoagulation. Explanation: posterior epistaxis is often due to bleeding from the sphenopalatine artery and is more severe in anticoagulated patients. A. Anterior packing is ineffective for posterior bleeding. B. Silver nitrate cauterization works for anterior epistaxis but is insufficient for posterior bleeds. D. Observation alone is inappropriate in an actively bleeding patient. Initial management includes posterior nasal packing, inner correction with vitamin K or FFP, and, if bleeding persists, endoscopic sphenopalatine artery ligation. Question 13. Topic: Otology. Cholesteatoma. 35-year-old man presents with chronic otorrhea, conductive hearing loss, and foul-smelling discharge from his left ear. Examination reveals retracted tympanic membrane with pearly white mass in the pars flaccida. What is the best next step in management? A. Audiometry and observation. B. Tympanostomy tube placement. C. CT scan and surgical removal. D. Topical antibiotics. Answer: C. CT scan and surgical removal. Explanation: this is suggestive of cholesteatoma, which is an aggressive, destructive keratinizing lesion that can cause ossicular erosion, facial nerve paralysis, and intracranial complications. A. Observation is inappropriate as cholesteatomas do not resolve spontaneously. B. Tympanostomy tubes do not treat cholesteatomas. D. Topical antibiotics may control infection but do not remove the lesion. Definitive treatment is surgical excision via tympanomastoidectomy. Question 14. Topic: Head and neck trauma. Laryngeal fracture. 28-year-old motorcyclist presents with hoarseness, stridor, and subcutaneous emphysema following high-speed collision. CT imaging reveals laryngeal fracture with displaced cartilage. What is the next step in management? A. Immediate endotracheal intubation. B. Urgent tracheostomy and surgical repair. C. High-dose steroids and voice rest. D. Non-surgical observation. Answer: B. Urgent tracheostomy and surgical repair. Explanation: a laryngeal fracture with airway compromise requires immediate airway stabilization, often with tracheostomy rather than intubation, to avoid worsening injury. Surgical repair restores laryngeal function. A. Intubation can worsen the fracture and is avoided unless necessary. C. Steroids may reduce edema but do not address the structural damage. D. Non-surgical observation is only appropriate for mild, non-displaced fractures. Early airway management reduces the risk of permanent voice and airway dysfunction. Question 15. Topic: Rhinology. Chronic rhinosinusitis with nasal polyps. 45-year-old man presents with chronic nasal congestion, anosmia, and postnasal drainage for the past year. He has history of asthma and aspirin sensitivity. Nasal endoscopy reveals bilateral nasal polyps. CT scan of the sinuses shows diffuse mucosal thickening without bony destruction. What is the most appropriate first-line treatment? A. Oral corticosteroids followed by intranasal steroids. B. Functional endoscopic sinus surgery (FES). C. Aspirin desensitization therapy. D. Antihistamines and nasal decongestants. Answer: A. Oral corticosteroids followed by intranasal steroids. Explanation: This patient has chronic rhinosinusitis with nasal polyp or out of aspirin-exacerbated respiratory disease (ED). First-line therapy includes oral corticosteroids, prednisone 4060 mg daily for 510 days to reduce inflammation. Intranasal corticosteroids fluticasone budesonide to maintain symptom control. B. Surgery (FES) is considered only if medical therapy fails. C. Aspirin desensitization is an option for AID patients but not first line. D. Antihistamines decongestants do not address the underlying inflammatory process. Long-term management includes biologic agents, dupilumab, for refractory cases. Question 16. Topic: Laryngology. Vocal cord paralysis. 60-year-old woman presents with progressive hoarseness and mild dysphagia for the past 3 months. She denies smoking or alcohol use. Flexible laryngoscopy shows left vocal cord paralysis in the paramedian position. What is the most appropriate next step? A. CT scan of the neck and chest. B. Vocal cord injection with hyaluronic acid. C. Voice therapy. D. Empiric proton pump inhibitor (PPI) therapy. Answer: A. CT scan of the neck and chest. Explanation: Unilateral vocal cord paralysis may indicate recurrent laryngeal nerve RNN involvement, which requires imaging to rule out malignancy, lung, thyroid, esophageal, mediastinal tumors. B. Vocal cord injection is considered for voice rehabilitation after malignancy is excluded. C. Voice therapy is beneficial after the cause is identified. D. PPI therapy, laryngopharyngeal reflux (LPR), but does not explain vocal cord paralysis. Echo from the skull base to the mediastinum is essential to locate the lesion along the RNN pathway. Question 17. Topic: Otology. Vestibular neuritis. 34-year-old woman presents with acute onset severe vertigo, nausea, and vomiting that started 12 hours ago. She reports no hearing loss or tinnitus. Physical exam reveals right beating horizontal nystagmus that worsens when she gazes to the right. The head impulse test is positive. What is the most appropriate initial treatment? A. Corticosteroids and vestibular rehabilitation. B. Meclizine and benzodiazepines. C. MRI brain with contrast. D. Intravenous antibiotics. Answer: A. Corticosteroids and vestibular rehabilitation. Explanation: This presentation is vestibular neuritis, an acute viral or post-viral inflammation of the vestibular nerve causing persistent vertigo without hearing loss. B. Meclizine and benzodiazepines provide symptomatic relief but delay central compensation. C. MRI brain is indicated if there are neurologic symptoms suggesting stroke. Roman antibiotics are needed for bacterial labyrinthitis but not viral vestibular neuritis. Vestibular rehabilitation exercises, Cawthorne-Cooksey, promote compensation and recovery. Question 18. Topic: Head and neck oncology. Salivary gland tumors. 55-year-old man presents with slow-growing, painless left parotid mass for 6 months. Examination reveals firm, mobile, 3 cm mass without facial nerve involvement. What is the most appropriate next step? A. Fine needle aspiration (FNA). B. Superficial parotidectomy. C. MRI of the parotid gland. D. Antibiotics and observation. Answer: A. Fine needle aspiration (FNA). Explanation: Salivary gland tumors are most commonly pleomorphic adenomas, but malignancy must be ruled out. FNA helps differentiate benign from malignant lesions before surgical planning. B. Surgery peritidectomy is required for confirmed tumors, but FNA must be done first. C. MRI can assess deep lobe extension but does not replace FNA biopsy. D. Observation is inappropriate as the mass is persistent. Definitive treatment for benign tumors is peritidectomy with facial nerve preservation. Question 19. Topic: head and neck trauma. Mandibular fracture. 30-year-old man presents after physical assault, complaining of jaw pain, malocclusion, and difficulty opening his mouth. Examination shows bruising along the right mandible and sublingual hematoma. What is the most appropriate next step? A. Panoramic X-ray or CT of the mandible. B. Immediate maxillomandibular fixation. C. Empiromine antibiotics and discharge. D. Soft diet and follow-up in 2 weeks. Answer: A. Panoramic X-ray or CT of the mandible. Explanation: a mandibular fracture must be evaluated with imaging. CT scan is preferred for complex fractures. B. Maxillomandibular fixation is used for displaced fractures but requires confirmation. B. Roman antibiotics are used for open fractures but imaging comes first. D. Soft diet may be considered for non-displaced fractures but diagnosis must be confirmed. Question 20. Topic: Otology. Meniere's disease. 42-year-old man presents with episodic vertigo, fluctuating hearing loss, tinnitus, and oral fullness in the right ear. Episodes last several hours. Audiometry shows low-frequency sensorineural hearing loss in the affected ear. What is the best initial treatment? A. Low-sodium diet and diuretics. B. Intratympanic gentamicin. C. MRI brain with contrast. D. Surgical labyrinthectomy. Answer: A. Low-sodium diet and diuretics. Explanation: Meniere's disease is caused by endolymphatic hydrops and initial treatment includes low-sodium diet, 1.5 grams per diuretic HETE, acetazolamide. B. Intratympanic gentamicin is for refractory cases. C. MRI is for atypical cases, but not the first-line treatment. D. Labyrinthectomy is last resort for severe, intractable cases. Long-term management includes vestibular rehabilitation and steroid therapy for flare-ups. Question 21. Topic: Otology. Sudden sensorineural hearing loss SHR. 50-year-old woman presents with sudden onset hearing loss in her right ear that occurred 2 days ago. She describes feeling of fullness in the ear but denies pain or fever. Tuning fork tests show Weber lateralizing to the left and RIN positive bilaterally. Audiometry confirms 35 dB sensorineural hearing loss in the right ear. What is the best next step in management? A. High-dose oral corticosteroids. B. MRI of the brain and internal auditory canal. C. Hyperbaric oxygen therapy. D. Empiric antiviral therapy. Answer: A. High-dose oral corticosteroids. Explanation: this patient has idiopathic sudden sensorineural hearing loss SHR, defined as a loss of 30 dB in 3 consecutive frequencies within 72 hours. The first-line treatment is oral corticosteroids, prednisone 60 mg daily for 7-14 days with taper. MRI is indicated if symptoms persist or if there are neurological signs suggestive of vestibular. C. Hyperbaric oxygen therapy is considered adjunctive if started within 2 weeks. D. Antivirals are not effective unless viral cause, herpes zoster, is suspected. Prompt treatment increases the chance of partial or complete hearing recovery. Question 22. Topic: Rhinology. Allergic fungal rhinosinusitis AFUS. 32-year-old man presents with nasal congestion, headache, and facial pressure for the past 6 months. He has history of seasonal allergies and asthma. Nasal endoscopy reveals thick, greenish mucus and polyps. CT scan shows hyperdense material with double density assigned and bony expansion of the sinuses without erosion. What is the most appropriate treatment? A. Functional endoscopic sinus surgery FES. B. Long-term antibiotics. C. Antifungal therapy. D. Oral decongestants and nasal irrigation. Answer: A. Functional endoscopic sinus surgery FES. Explanation: this patient has allergic fungal rhinosinusitis AFUS characterized by nasal polyps, thick eosinophilic mucin, and bony expansion of the sinuses. Treatment includes surgical debridement FES to remove fungal debris and polyps, intranasal corticosteroids to reduce inflammation, long-term immunotherapy or antihistamines to manage allergies. B. Antibiotics are ineffective since AFUS is not bacterial. C. Antifungals are not routinely used as AFUS is an allergic, not invasive fungal disease. D. Decongestants and irrigation provide symptom relief but do not treat AFUS. Surgery is crucial to prevent sinus obstruction and recurrence. Question 23. Topic: Pediatric otolaryngology. Laryngomalacia. 3-month-old infant presents with noisy breathing since birth that worsens when feeding or lying supine. Parents describe high-pitched inspiratory stridor that improves when the baby is held upright. Flexible laryngoscopy reveals omega-shaped epiglottis and redundant arytenoid tissue. What is the best next step in management? A. Reassurance and close follow-up. B. Supraglotoplasty. C. Tracheostomy. D. Empiric proton pump inhibitor PPI therapy. Answer: A. Reassurance and close follow-up. Explanation: Laryngomalacia is the most common cause of congenital stridor. It is due to immature laryngeal cartilage collapse during inspiration. Most cases resolve spontaneously by age 1 to 18 months. B. Supraglotoplasty is indicated only for severe cases with failure to thrive, respiratory distress, or apnea. C. Tracheostomy is reserved for life-threatening airway obstruction. D. PPIs may be used if GERD is suspected, but they do not treat laryngomalacia itself. Parents should be reassured, and follow-up is recommended to monitor symptoms. Question 24. Topic: Head and neck. Zenker's diverticulum. 65-year-old man presents with progressive dysphagia, regurgitation of undigested food, and chronic halitosis. He occasionally experiences choking while eating. Barium swallow. Study shows posterior outpouching at the level of the upper esophageal sphincter. What is the most appropriate treatment? A. Endoscopic diverticulotomy. B. Botulinum toxin injection. C. Esophageal dilation. D. Proton pump inhibitor therapy. Answer: A. Endoscopic diverticulotomy. Explanation: This patient has Zenker's diverticulum pharyngosophageal pouch caused by cricopharyngeal muscle dysfunction. Endoscopic diverticulotomy or cricopharyngiotomy is the preferred treatment for symptomatic patients. B. Botulinum toxin is used for achalasia, not Zenker's. C. Dilation is ineffective as Zenker's is not due to strictures. D. PPIs do not address the anatomic cause. Surgical correction prevents aspiration pneumonia and malnutrition. Question 25. Topic: Otology. Cholestetoma. 43-year-old woman presents with chronic ear discharge, hearing loss, and intermittent ear pain. Otoscopic exam reveals retraction pocket with keratin debris in the pars flaccida. Audiometry shows conductive hearing loss in the affected ear. What is the next step in management? A. CT of the temporal bone. B. Topical and oral antibiotics. C. Tympanostomy tube placement. D. MRI with gadolinium. Answer: A. CT of the temporal bone. Explanation: Cholestetoma is an abnormal collection of keratinizing epithelium in the middle ear, which can lead to ossicular erosion and intracranial complications. B. Antibiotics treat infections but do not remove the cholestetoma. C. Tympanostomy tubes are used for chronic otitis media, not cholestetomas. D. MRI is used for complications like temporal bone abscess or sigmoid thrombosis. Definitive treatment is surgical excision, tympanomastoidectomy. Question 26. Topic: Laryngology. Recurrent respiratory papillomatus OP. 5-year-old boy presents with progressive hoarseness and stridor. He has no history of recurrent infections or asthma. Flexible laryngoscopy reveals multiple exophytic lesions on the true vocal cords. What is the most likely cause of a HEV infection? B. Allergic laryngitis. C. Vocal cord nodules. D. Bacterial laryngitis. Answer: HEV infection. Explanation: RPs caused by HEV type 6 and 11, acquired perinatally or via sexual transmission in adults. BD. Other causes do not present with exophytic growths. Treatment includes microlaryngoscopy with laser excision and adjuvant therapies, cidofovir, bevacizumab for recurrent cases. Question 27. Topic: Otology. Vestibular neuritis. 42-year-old woman presents with acute onset severe vertigo, nausea, and vomiting that started 2 days ago. She denies hearing loss or tinnitus. Physical examination reveals horizontal unidirectional nystagmus that worsens when looking toward the fast phase and improves with fixation. The head impulse test is positive. What is the most likely diagnosis? A. Benign paroxysmal positional vertigo. B. Meniere's disease. C. Vestibular neuritis. D. Acoustic neuroma. Answer: C. Vestibular neuritis. Explanation: Vestibular neuritis is caused by viral inflammation of the vestibular nerve, leading to sudden severe vertigo with preserved hearing. Key findings include unidirectional horizontal nystagmus, fast phase away from the affected side, positive head impulse test, corrective saccade when turning toward the affected ear. No hearing loss differentiates from labyrinthitis and Meniere's disease. Treatment in vestibular rehabilitation therapy and corticosteroids. APPV causes episodic vertigo with positional triggers and is diagnosed with the Dix-Hallpike maneuver. B. Meniere's disease presents with episodic vertigo, fluctuating hearing loss, and tinnitus. D. Acoustic neuroma presents with gradual hearing loss and imbalance, not acute vertigo. Question 28. Topic: Pediatric otolaryngology. Choanal atresia. Newborn girl has cyanosis that improves when she cries and worsens when feeding. Physical examination shows nasal obstruction. Flexible nasopharyngoscopy confirms unilateral bony obstruction of the choana. What is the best next step? A. Immediate surgical correction. B. Oropharyngeal airway placement and feeding modifications. C. Empiric antibiotics and nasal steroids. D. Observation with follow-up at 1 month. Answer: B. Oropharyngeal airway placement and feeding modifications. Explanation: choanal atresia is a congenital obstruction of the nasal passage. Bilateral cases present with respiratory distress at birth, while unilateral cases may be asymptomatic until later in infancy. A surgery endoscopic repair is definitive but not emergent in unilateral cases. C. Antibiotics are not required unless infection is present. D. Observation alone is not appropriate as feeding difficulties require intervention. For bilateral atresia, immediate airway management, e.g. oral airway intubation, is required. Question 29. Topic: Head and neck. Branchial cleft cyst. 20-year-old woman presents with painless, fluctuant mass along the anterior border of the sternocleidomastoid muscle. She reports mild swelling that increases with upper respiratory infections. Examination reveals soft, non-tender cystic lesion at the level of the hyoid bone. What is the most appropriate management? A. Fine needle aspiration with observation. B. Empiric antibiotics and follow-up. C. Surgical excision. D. Corticosteroid injection. Correct answer: C. Surgical excision. Explanation: a branchial cleft cyst is a congenital epithelial cyst that arises from remnants of the branchial apparatus. It commonly presents in young adults following an upper respiratory infection. A fine needle aspiration is not necessary unless malignancy is suspected. B. Antibiotics may reduce secondary infections but do not prevent recurrence. D. Corticosteroids do not resolve the cyst. Surgical excision is recommended to prevent recurrent infections and potential abscess formation. Question 30. Topic: Laryngology. Vocal cord paralysis. 55-year-old man with history of lung cancer presents with hoarseness and breathy voice for 2 months. Flexible laryngoscopy reveals unilateral left vocal cord paralysis. What is the next step in management? A. CT scan of the chest and neck. B. Speech therapy. C. Vocal cord injection. D. Bilateral thyroplasty. Answer: A CT scan of the chest and neck. Explanation: unilateral vocal cord paralysis can result from recurrent laryngeal nerve injury due to lung cancer, thyroid surgery, or idiopathic causes. Left-sided paralysis is concerning for a mediastinal or lung mass compressing the recurrent laryngeal nerve. B. Speech therapy can improve symptoms but does not identify the cause. C. Vocal cord injection is considered after ruling malignancy. D. Bilateral thyroplasty is not appropriate for unilateral paralysis. Echani of the chest and neck is essential to evaluate for malignancy.